Hi everyone, my name is Rachel, and today we will be discussing a couple different cases about two patients and their diagnoses. So the first case is a 16-year-old female who's recently diagnosed with a deficiency of muscle glycogen phosphorylase, and she and her family have some concerns, so they asked some questions about it. So the first question is, not sure I understand the issue. Can you explain how muscle glycogen is used during exercise? So glycogen produces the primary energy source for muscles to maintain contractions during exercise. Most glycogen is stored either in the liver or in the muscles. Hepatic glycogen helps maintain blood glucose levels, while muscle glycogen breaks down to allow contractions. Glycogenolysis is what we call the pathway by which glycogen is broken down into glucose. And this process begins with the enzyme glycogen phosphorylase, which catalyzes the release of glucose from the ends of those glycogen branches. ATP is the name of the usable form of energy that the body needs, which is produced by the oxidation of glucose in the bloodstream from the intramuscular glycogen stores. So the next question is, she really likes to take long walks with her friends, and she wants to know if she'll still be able to do that. So the rate of glycogen depletion during exercise is directly related to exercise intensity. During exercise, at least 60% of the maximum intensity, or VO2 max, which is your maximum oxygen uptake, muscle glycogen is the primary fuel oxidized to produce that ATP. At lower intensities, free fatty acids from intramuscular triglyceride stores are oxidized into ATP. So you'll be able to continue lower intensity exercise, such as walking. However, higher intensity exercise may be difficult for more than just a couple minutes. Low to moderate intensity exercise might actually be beneficial for people with this condition because it'll allow you basically to get the most out of your limited ability to use glycogen by depleting it much slower. But you need to keep in mind that you can experience some side effects during exercise, like muscle pain, cramping, weakness, just from the limited fuel. Next question is, as a result of this deficiency, does she need to get up at night to maintain blood glucose levels? So symptoms of muscle glycogen phosphorylase deficiency can often be managed with certain diet and lifestyle changes. This includes consuming a diet rich in carbohydrates and a little bit lower in protein. It might also be beneficial to supplement before exercise with food and drinks that are high in sucrose. You don't need to wake up at night in order to maintain your blood glucose levels, but you need to make sure that your hepatic glycogen stores are full by eating throughout the day, eating 3 meals and whatnot, so that your blood glucose levels can be maintained while at rest overnight. And the final question is, do I need to worry about producing excess lactate during intense anaerobic exercise? So during high intensity exercise, second wind phenomenon is an issue that you need to be aware of. This is when somebody suddenly feels a burst of energy a few minutes into exercise and feels like they can keep going at high intensities. And this can cause serious issues such as rhabdomyolysis, which is when muscle starts breaking down to keep fueling the body. So you don't generally need to be super concerned about excess lactate during anaerobic exercise unless you're really overdoing it. In the case of people with muscle glycogen phosphorylase deficiency, lactate uptake often exceeds lactate release, which results in a net positive uptake. And this results in subsequent oxidation by the active muscles during exercise. So lactate is actually going to serve as an alternate fuel source for you in your muscles during exercise. So the second case that we're going to talk about is a previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports that she has not ever had anything to eat other than breast milk since birth, and she has only recently started sleeping for more than 2 hours and going more than 2 hours between feedings, and that's when her symptoms suddenly began. Her lab results show hypoglycemia, but otherwise are unremarkable, and She's given epinephrine and has an increase in lactate with no increase in blood glucose. She was found to have an enlarged liver in her physical exam, and her glucose levels do rise right after feeding, but they don't stay in that healthy range. So for this, we'll begin by ruling out the incorrect possible diagnoses, and then we'll discuss the correct condition. So the first condition that we can rule out is hereditary fructose intolerance. This is typically diagnosed when weaning regular food into a child's diet and removing breast milk. Human milk is not considered to contain fructose naturally, and this child has only ever had breast milk, so that makes this a very unlikely possibility. The next disorder that can be ruled out is galactosemia. This is a genetic condition that is usually caught right after birth during a newborn screening, and it is usually life-threatening if lactose is not removed from the diet immediately, and this needs to happen within the first 10 days of life. This child has been consuming breast milk, which is very high in lactose, for 2 months without issues, so that is probably not what is occurring here. The final condition that we can rule out is glucose 6-phosphate dehydrogenase deficiency. So symptoms of this can begin in the first couple months of life, but symptoms are usually dark urine, fatigue, paleness, rapid heart rate, shortness of breath, jaundice. So they don't really match with this patient's presentation. Enzyme deficiency alone, though, is not enough to trigger the onset of symptoms with this condition. And exposure to certain infectious diseases or drugs or foods such as fava beans is required to trigger an episode of symptoms here. We have nothing indicating that this child has been exposed to any of those things. So we can pretty safely rule this out. The correct diagnosis here, based on her presentation, her exam, is glycogen storage disease. This is a hereditary condition that's usually diagnosed between 2 and 4 months of age, and it's caused by the lack of enzymes responsible for converting glycogen into glucose. So her physical exam showed an enlarged liver, which is typical in this case due to the accumulation of glycogen and fat in the liver that is not able to be released into the bloodstream as glucose. The mother also stated that symptoms like jittery spells appeared once she started sleeping longer and going longer between feedings. This is likely due to severe hypoglycemia between feedings that's causing seizures or other cognitive impairments that the mother is seeing as, quote, jittery spells. So a common way to test for glycogen storage disease is an epinephrine challenge test, which is where a single dose of epinephrine is given and the patient's response is monitored. So in a healthy patient, blood glucose and blood lactate should both increase in response to epinephrine. But with this condition, lactate increases and glucose stays the same. This is because epinephrine accelerates glycogenolysis in order to maintain blood glucose levels during stress. Also, in the cases of stress, such as with elevated epinephrine, skeletal muscles will release more lactate for oxidation into energy in response to the stress. So based on the symptoms that the mother reports and the baby's physical exam, we can pretty confidently rule out all other diagnoses and say that she has glycogen storage disease.